Now, last presentation of this session, I request Dr. Apo to present on uniportal spine endoscopy as decreased ACDH.
Hello, good afternoon. Thank you, Dr. Lim, and thank you, Dr. Incheon, other organizers and sponsors. I'm Dr. Akbar. I'm a surgeon from Uzbekistan. I do a short talk about because uniportal endoscopy, I'm an uniportal surgeon. After starting his endoscopy, cervical part, SCDF before endoscope, more surgeons did is SCDF. Nowadays, after endoscopy, SCDF is number of cases are falling down because this uniportal endoscopy gives us many opportunity do posterior approach to do because after open surgery more muscle damages after this kyphotic changes. That's why open surgery is posterior is for patient is best. It's why endoscopy is giving us more advantages, prevent cervical muscles, targeting wall, and no damaging anatomical structure, saving bony structure, and bilateral decompression can do paraminatomy and extraforaminal discalation. And paraminal discalation can remove with posterior approach. Why SCDF cases are falling down is it because of posterior approach. I also do is more posterior approach. Dr. Son talked about pathological anatomy because each surgeon will have to know his pathological anatomy because we don't do his normal anatomy because more patients are having is not central canals because of this normal anatomy we can see is normal is foramen, but this after prolapse disc is more foraminal stenosis, more patients are having. That's why we have to understand. I understand if central part, main part of central compression is SCDF required. If foraminal stenosis is foraminal discalation, we don't need if stable, we don't need ECDF, just posterior approach is enough. I understand if like this cases is unstable spine require fusion, but stable if when we do X-ray dynamic is not stable spine. We don't know like such fusion cases nowadays. I explained one cases. This patient, 65 years old, came to me with myelopathy symptoms, and many doctors recommended ECDF. Patient didn't want ECDF and came to me. I did dynamic X-rays, stable spine, and I explained it can do endoscopically posterior approach, no implants, no cases, no fixation. This is video 5667 right side approach. Can do if interlaminar space is enough, can do first, can start with kersin, as well as narrow space first we need to remove bone withdrawal. Just make sure now this technique, if no adhesion between dura and phlegm, can remove full part, but if adhesions, better is cut a small piece kerosene. When we use kerosene, we have to be careful. Our kerosene is not pushing down this cord because it easily damages spinal cord. This bilateral is the compression is now 5-6. Now with sliding technique can start next level 6-7 decompression. We don't need other approach. This next level 6-7 I'm starting. First is we have to nose into laminar. When we remove soft tissue and fats, we can see it's the ligamentum flavum. And because you at least the lamina is thick, can remove this kerosene easily. Is bone structure as much as we need. There's attachment of ligamentum flavum. Yeah, if lamina is not thick, first upper part can remove this ribs, and this is kerosene 1 mm because more stenosis. That's why I didn't use this time kerosene 2. If enough space, you can use the kerosene 2. This is contralateral approach I'm doing. This is ipsilateral approach, ipsilateral root decompression also. It's the time. This is ISECSS lamina. We don't do is totally lamina ectomia. We can save lamina. It's just like lumbar. Can do with laminar bilateral decompression. If such as a bone bleeding, use bone wax for stop bleeding. C is post-op MRI. Is immediately second day. No muscle damages. This is before and after surgery. Totally bilateral decompression. Enough space for spinal cord. No hematoma. Thank you for attention.